I want to just thank Augie for inviting me here. She said this is my first time. Hopefully I'll be here in the years to come as well. I'd like to thank Bill and Howard, of course, for being here and for all of you to be here today. So in putting this talk together, I really was kind of thinking, what would I want to discuss? And I think I chose an approach to just sort of say, what are the ways that we can be of assistance to you? And in terms of, as Howard referred to, in terms of diagnosing, which is what I'm going to spend a good amount of my talk on. But as he alluded to, we may be increasingly playing a role in therapy. And I want to sort of just kind of give you a little teaser as to some of the things that are there. I'm going to show some videos here, so hopefully they'll play okay, and we'll go. So I'm going to really talk about three main areas: diagnosis and staging of pancreatic cancer, particularly adenocarcinoma, talking about assessment of pancreatic cysts. We know that pancreatic cysts are increasingly being identified, and some of these have malignant potential, and sort of how to work through those and identify the ones that are of most concern and predict which patients should undergo resection is something that continues to challenge us and that we work with. And I'll sort of describe some areas that we may be of assistance with, and then talk about some both palliative therapies and potentially new therapies for actual direct treatment of these tumors. So the first step is, of course, is that if you've got a patient and you suspect a cancer, you have to first find it. And we've talked about how these tumors generally present somewhat later when they become symptomatic. They're often advanced. But when you sort of suspect cancer, maybe at a somewhat earlier stage with maybe minimal symptoms, of course, we typically get some form of cross-sectional radiologic imaging, usually a CT scan, often what's referred to as a Pancreas protocol, which are very sort of fine cuts so that you avoid missing small lesions. And if a mass, of course, is present at that time, we then assess and evaluate the resectability that Dr. Donahue so nicely discussed just before. But if you don't see a mass, what do you do in that situation? And I would argue that if you don't see a mass on these tests and you still have a strong clinical suspicion, either your doctor, yourself, or the two, that you're really not done at that point. You really should undergo an endoscopic ultrasound, or EUS. And this is a scope that has, it's an endoscope that has an ultrasound processor built in, and we basically can look at all portions of the pancreas very nicely through the back wall of the stomach and the beginning of the small bowel. And so probably the best way to highlight this is actually to sort of show a case. And this, I'm not sure if I've ever shared this with Dr. Reber, but this was a case that I did right when I finished my training in endoscopic ultrasound. I went back to UCSF, which I was the director of EUS there for a few years in the early 2000s. And so this was a patient who came who had some suspicion of some abdominal pain. I'm not saying that cancer was the first thing on everybody's mind, but certainly the patient certainly had some concerns about that. And underwent a CT, an MRI, and at that time an ERCP, which again is an endoscopic procedure to look at the bile duct and pancreas ducts. And all of those tests were normal. And of course, I, being the new guy who had just come up there with this new test, eventually got asked to see this patient. We ended up doing an endoscopic ultrasound, and even a bit to my surprise, we found a small lesion, which you can see here, and this was 13 by 13 millimeters. Now, we could probably discuss whether I needed to biopsy this. I would say that probably at our institution here, we probably would just resect this patient because it looks like it's something that is highly suspicious. But I knew no one would believe me with 3 negative tests, so I ended up biopsying this patient. It was adenocarcinoma, and then I contacted a well-known pancreas surgeon and a former colleague of Dr. Reber's, Dr. Way at UCSF, and told him, I found a very early stage pancreas cancer. This is a T1 pancreas cancer, he said, okay, thank you, and then he went to see Dr. Way, and I later found out that the patient had all 3 tests repeated because he was so surprised that we had found this with all the other tests being negative. And then he called me back a few weeks later and said, I want you to repeat that ultrasound and re-biopsy the pancreas. And I said, why? I said, I think I've proven my case. And he says, well, I've done 6 tests and nobody can see this but you. And so I said, I'll do it under one circumstance, that you come stand next to me while I do it. And he said, okay, fine. He took the patient to the operating room and sort of he provided me with this photo, which shows a 13 by 13 millimeter lesion, which does not connect to the pancreas duct, which is why the ERCP was negative. This patient sent me a Christmas card for 9 consecutive years. I've moved enough now that he's lost track of my address, but we're Facebook friends, so I know he's still doing well. So this is what we're hoping to find. We don't see this enough, but I would say that EUS has a tremendous role in detection, particularly in small tumors, and those are the ones, of course, I think we can impact the greatest. So once you've found your cancer, what are your questions? I think Tim sort of discussed this very nicely. You want to sort of, figure out which patients are appropriate for direct surgical resection, and we want to try to appropriately stage people so that our surgeons don't find advanced disease at the time of the operating room and subject the patient to the operation without a resection. And again, this is done by sort of assessing both the location of the tumor, its relationship to vessels, looking to see if there are lymph nodes, and it's looking to see if there's evidence of advanced disease. So, again, this patient I just showed you is one of the fortunate folks that are in the resectable category. We often find folks on imaging who had advanced disease, distant lymph nodes or lesions that have spread to the liver, lungs, or into the general abdomen as what we call carcinomatosis. And I think, as Tim nicely described, that we have most of the patients tend to follow with what we call locally advanced or borderline disease, which is the tumor is essentially still in the pancreas, but is sort of wrapped around the many vessels that are in that area to the point where removing it becomes a bit of a challenge. And again, there's concern for microscopic spread of disease elsewhere, and increasingly we're treating these patients up front with chemotherapy. So EUS can help kind of assess these lesions. This is a patient, again, in EUS, the tumors look dark, so this is a tumor. The pancreas is the bright part here, and then this is one vessel, and this is another vessel. And the point I'm trying to sort of emphasize is that here we have a tumor that does not appear to involve a vessel, and this is a patient that we would deem by ultrasound to be resectable. And again, the tumor here being the brown dot here, here's the pancreas, and again, here are the major vessels that we worry about, and these are not involved. Now here's another patient who has a larger lesion. Here's the mass. Here's the aorta, and then this is the superior mesenteric artery, which is one of the vessels that we'd like to see not involved. But unfortunately, this dark mass sort of connects right up to this vessel here, and this is actually involvement of this vessel. This patient was not felt to be a candidate for surgery. This is a locally advanced disease because, again, the brown tumor involves the vessel here, and this is someone who would best benefit from upfront chemotherapy. And then borderline resectable is usually when you don't have clear involvement of the artery, and the vein may have some involvement, but not full encasement, for example. So here's an example again of a dark tumor that we're seeing on ultrasound. Here's the artery with this sort of bright area sort of separating it from the tumor, so the artery does not appear to be involved, but we see this sort of tumor sort of touching up against the SMV in a couple of points here. And again, this patient, again, depends on the location, but increasingly these patients are undergoing pre-surgical therapy. So we talked about staging sort of for local, but the other advantage of EUS at times is we sometimes can find small pockets of advanced disease. And again, our role really is to help avoid unexpected surprises at the time of surgery. So this was a patient who had a pancreatic tail lesion that I was asked to biopsy many years ago, and then here's the tumor here. But when I noticed right next to the tumor that next to the stomach wall there's a small collection of fluid, and I was able to take my needle and put it into that fluid and diagnose a small amount of tumor within there. And so, again, the idea is to get the sort of best accuracy for staging without having to do it through an open operation. So here's an example of how we sort of get tissue. Oh, it looks like it's all right. Well, this is an example of a small mass here, and again, this is typically we take a small needle and we're able to biopsy these. This is a 1 centimeter mass, and we can get tissue. And going back to the point, we can now get core samples for these specimens as well. So, and the reason that that's important is that from that we can often run specific molecular diagnostics so that we can obtain sensitivities for certain specific chemotherapeutics, for example, so we can sort of perform personalized therapy. So these are, again, advances that we're able to take. So we're now not only able to just get individual cells, but actually get a core sample of tissue to help assess architecture and get enough material so that we can run some of these molecular markers. So indications for tissue diagnosis in patients with suspected pancreas cancer. Again, our goal is obviously to biopsy tissue in areas that suggest metastatic disease to properly stage patients and maybe avoid operations that may not be indicated. In patients who are at high risk for surgery or there's some concern about whether what's seen is actually representing a true mass, we can biopsy those areas as well to confirm a diagnosis or to exclude a diagnosis. And then occasionally we'll find a patient who may have a history of a previous cancer, which could be potentially have spread to the pancreas, and it may not be a primary pancreas cancer. I was at a live endoscopy course a few months ago where we had a patient who had a pancreatic mass and several liver lesions, but it turned out they'd had a melanoma many years before, and it turns out that the actual lesions were melanoma that had spread to both the liver and the pancreas. And so that actually made a big difference in the diagnosis in terms of the way that that patient was ultimately treated. One could argue a biopsy may not always be needed. For example, I would argue the patient I presented to you just a few minutes ago with a pretty focal mass that looks resectable, not a lot of other potentials in that patient, might be somebody who you could just take directly to surgery. I had biopsied, of course, at that time because I knew there would be suspicion about its presence given the numerous other negative studies. And another way that we can help is to sometimes mark these lesions. So pancreatic neuroendocrine tumors are usually very focal lesions, which sometimes can undergo very minimal resection, sometimes enucleations or limited resections of the pancreas. And finding these lesions can be sometimes difficult. And one of the techniques we can do is actually put a little tattoo. So when we diagnose the lesion, we can put a little ink spot so that our surgical colleagues can find these lesions a little bit easier and then either perform a more minimal resection or at least expedite their operation because they don't have to spend as much time looking for the lesion. So that's a little bit about solid pancreas lesions and sort of in the role of endoscopic ultrasound in both in terms of diagnosis and detection. I'll sort of move a little bit towards pancreatic cysts now. So pancreatic cysts are increasingly being identified, and we see that if many studies suggest that 1 in 40 people who undergo a scan for any reason are going to have some sort of a cyst, and it looks like that number increases as you age. So probably the most cited study is a study in black here, which shows that probably about 10% of people by the time they get to age 70 will have a pancreatic cyst. And so in that situation, we have to sort of decide, many of these cysts will turn out not to have any clinical consequence, but some of them can turn into have the potential to be, pre-neoplastic or neoplastic. And so we're increasingly asked to sort of come up with a way to stratify these cysts into what they are. And this is sort of a busy slide just showing what the different things are, but essentially we have several cysts that are truly non-neoplastic. Some have a very low level of malignant potential. Some are solid lesions that have just sort of become sort of liquefied. And then there are the true cystic lesions. Specifically, I'm going to focus on mucinous cystadenomas and intraductal papillary mucinous neoplasms. And these are both lesions that carry some risk of turning into pancreas cancer. And our goal then is to try to differentiate these mucinous lesions from non-mucinous lesions, and how do we go about doing that? So again, these mucinous lesions are again usually singular. They often have lined with a specific type of lining called an ovarian stroma. They usually have one or a few pockets. They're usually located in the tail of the pancreas, which is the left side, and the risk of malignancy is around 15%. There's some variability in the different studies, but there is clearly some malignant potential for these lesions over time. And then this is a CT scan showing essentially, again, this is the tail of the pancreas, the spleen, the kidney, and you see sort of this one sort of cyst here in the region of the tail, which represents a mucinous cystic neoplasm. Now, the other type of neoplasm is this IPMN lesion, which is increasingly being recognized. And this is sometimes the classic finding, although you don't usually see this, is you'll see this mucin coming out of the opening of the pancreas duct. Again, these are more common in men, particularly the main duct IPMN type, which I'll get to in a second, and they're usually located more on the right side of the pancreas, the head side. And again, these have a significant risk of developing into cancer, probably between 40 and 65%, and these are typically managed with surgery. And again, the outcomes on these lesions often can be quite good if you catch them at the early stages of cancer as they're transforming. There's a sort of, sometimes the main duct is actually not involved, but the side branches or the tributaries to the main river, so to speak, are involved. That still, however, can lead to a risk of cancer of up to 25%. And then there's something called a mixed type, where both the side branches are a little dilated as well as the main duct, and that's called a mixed type lesion. So here's some images sort of showing, again, here's the pancreatic duct, and this is somewhat enlarged, and I'll show you what a normal one looks like in a second here, but this is sort of a dilated main pancreatic duct. This is a significant risk for development of malignancy. This is a patient who has a normal main pancreatic duct. You can see how narrow that is here, but a large sort of lake off to the side here, and that's a side branch that you see there. Sometimes patients can have more than one side branch. They can be singular or multiple, as you see here. And then this is a patient who has not only the side branches, but the main duct is also dilated. So this is that sort of intermediate risk group, but again, this is something we usually treat. Again, this is to just summarize, again, these are the kinds of patients we see this in. So we usually see somewhat younger patients, female, more in the body tail, with these cysts that have one or a few pockets. And you can see that of all the mucinous cysts, these are, again, of all the pancreatic cystic neoplasms, this accounts for about a quarter. The IPMNs are probably more like a third to half, and again, they're more involving the head, more in men and older patients, and often associated with duct dilation. So what's the role of EUS? Well, we can sort of take a look at this in a variety of ways. We can sort of show the morphology. We can see sort of whether there's one pocket, multi-pockets. This looks like a little beehive here. There's lots of honeycombing here. This is more of a simple cyst with a nodule here. Here's another cyst with a nodule, and these nodules often represent early cancers growing within the cyst, and we can sometimes biopsy those directly. We can also obtain fluid from them. And so the role of EUS is really to identify what's in these cysts, both by general imaging, looking for nodules, assessing the shape, assessing its relationship to blood vessels in the main pancreatic duct, looking at the rest of the pancreas to see how the rest of the gland looks. But unfortunately, even with all that information, there's a lot of overlap between these cysts, and you may not always get an answer to that. So we can sometimes use needle aspiration of these cysts in order to demonstrate a little bit of additional information. So we can obtain fluid, which we can use to run for tumor markers like carcinoembryonic antigen, which is usually elevated in mucinous cysts, amylase to detect whether it's a pancreatic enzyme, to detect whether there's connection to the main pancreatic duct. And occasionally we can even identify malignant cells, although that's typically unusual with these cysts. They're not particularly cellular, so we often don't get that particular information. But the idea is to sort of, again, separate mucinous cysts from non-mucinous cysts. There's been some talk of using molecular analysis of the fluid to sort of see if we can come up with that. It has shown some promise, but I think it's still considered investigational because it's still not the sort of the magic answer that we've been hoping for, and it's often not covered by insurers at this point. This acquisition of this fluid is generally quite safe. Pancreatitis, bleeding, and fever typically occur at a rate of around 1%. And the idea, again, is this using the CEA marker, which for pancreatic cysts is usually elevated mucinous cysts. You see mucinous cysts and malignant cysts both have elevations versus the other types, the inflammatory and serous, do not. But again, CEA alone can't tell you if it's cancer or not. It can just pretty much tell you if it's mucinous or not. And again, this is just a summary. Again, the things that we're worried about are the mucinous cysts and IPMN. And mucinous cysts typically have thick fluid. They have a high CEA. IPMNs connect to the main pancreatic duct, so they also include pancreatic juice. The MCNs typically don't, and so usually have a low amylase. So here's a cyst that you can see. As we're looking at this cyst, you can see some nodules. There's actually more calcifications on the cyst. We can take a look. This is real time with the ultrasound. This is the main pancreatic duct, where we can see a direct connection between the two. And so this is how we assess sort of connection, morphology, shape of this, and that can give us a fair amount of information. But of course, the rest of the information typically comes from directly aspirating the cyst. So what about the role of ERCP, which again is this other technique that we have to sort of access the bile ducts and the pancreas ducts? We can often go in with a biopsy. We actually have scopes that go inside the channels of other scopes that we can take biopsies from. We also have even needles that we can pass probes through to sort of directly look into cysts. And again, this is, we can actually directly look into the main pancreatic duct in many of these patients and take a look at what's happening. So here's a patient that we were trying to decide whether they had a side branch IPMN, which sometimes can be observed, versus a mixed type where the main duct and the side branch are both involved, in which case that's someone that we would often operate on. And this was a patient we presented in our multidisciplinary conference. And so here we are, sort of, this is the opening of the bile duct and pancreas duct into the GI tract. We were sort of taking a probe with a wire and we access, you can see our little wire, black and yellow wire there going in. And then we'll get some x-ray here in a second just to sort of take a look and we confirm that we are in fact in the pancreas duct. Shoot a little bit of contrast. I'm just going to sort of slide forward in the interest of time. There's our little camera. This is the blue device here. So we're going to push that into the pancreas duct, into the area of interest, which was in the region of the neck. And then we start putting out our little optical probe here, which allows us to directly look inside the pancreas. So you're looking right inside the main pancreatic duct. And so we were trying to see if there were little fronds or papillary growths in this patient to determine if there was evidence of disease within the main pancreatic duct or if it was just the side branch. And it turned out what was happening, we felt in this case, was this is the opening to that side branch. You can see sort of a thick gelatinous sort of fluid there. And that was actually coming into the main duct and sort of causing an obstruction there just due to the thicker fluid, and the duct upstream was dilated. So it was kind of falsely masquerading, we felt, a mixed type, and we really felt it was side branch. And this actually made a difference in that this patient who was scheduled for an operation ultimately ended up being elected to be watched. So this is an example of where some of our technologies can actually help in terms of, and these are new techniques that really weren't available 5 or 6 years ago. So I'll cut back to the regular talk here. And so what about treatment? You know, again, this is very novel techniques, but we can actually use these, we can actually now inject alcohol, and sometimes even in certain chemotherapeutics like paclitaxel, in order to sort of ablate these cysts. The success rates have varied between 33 and 70%. So in certain patients with somewhat lower risk cysts who may not be great operative candidates, this may be an option in the future. This isn't quite ready for prime time yet, but these are some potential things for the future. You may still, even if you get rid of these cysts, you may still have to watch these patients, however, because you are at increased risk for pancreatic cancer in general from these. Next, we can sort of now go into these cysts within we can actually take a video camera and go directly into small cysts. And this is actually a picture of a cyst wall that we've taken directly through a needle and look at the cyst wall lining to better characterize what type it is. And we can even take forceps biopsies through that and try to determine what the lining wall is. This is a new technology that we just got in about a month ago, and so I'm about to do our first couple of cases with this. This is basically a confocal laser endomicroscope. It's basically a probe that acts like a microscope. And so I can go through the needle and actually sort of roll along the wall of these cysts to try to identify what type of cyst it is so we can better characterize these lesions. Again, we're really trying to, and the hope is that with patients who have a cyst that's very reassuring, we can reassure them and stop following them as closely. And for patients who we find an early lesion, we'll be able to intervene successfully at an earlier stage with hopefully better outcomes. So, and these are kind of the images you can get from that probe. This is sort of what you get from the probe, and this is what you get from the pathology when you resect the cyst. And you can see that there's essentially the ability to do real-time microscopy of these cysts. So the last couple of things that I'll sort of mention in closing is that we can do celiac neurolysis. So for example, many patients with pancreas cancer present with pain, and that pain can be quite debilitating. And one of the things we can do with endoscopic ultrasound is we can actually see the ganglia where many of those pain fibers sort of emanate from, and actually either sort of numb them or block them, or even perform what we call a neurolysis, which is destroy them with alcohol. We realize now that we can actually see these ganglia quite well. And in some studies, early studies have suggested that the majority of cancer patients pancreas cancer patients will achieve some benefit. And again, here's the aorta, here's the celiac artery, and then here's the ganglia here. And these are actually the nerves, and we can actually directly inject the ganglia. And I'll probably play one last video here if I can. So here we are, here's the aorta, we can actually see it encircled here, the ganglia. You can see we've got color, which tells us what's a blood vessel and what's not, so we can target this. There's our needle going directly into that ganglion, we can basically at that point inject right into this area a combination of usually an anesthetic and alcohol to destroy those nerves and to achieve pain control. So this is another technique that we can use to sort of help palliate patients. And then we also now can, and I'll just play these since these videos aren't loading up in here. This is an example of us injecting little markers at the edge of tumors to guide radiation therapy. So we know that patients who receive radiation therapy, we're trying to focus those beams in as narrow an area as possible to avoid collateral damage. And it's hard for them sometimes to see where the edges of the tumor are. So if we at the time of diagnosis can place a couple of radio opaque things that can be seen on X-ray, we place these little beads. They're often made of a little bit of gold, actually, and at least gold-plated. So they put these on, and we usually have 2 or 3 that we place to sort of mark the boundaries of the tumor. So here's our needle. You'll see this little bright area, and you can see them here, 1, 2, 3 here, and this marks the region of this fairly large tumor in the mid-body, and that allows them to sort of more accurately place and guide their radiation therapy. And then the last video I think I'll show here is brachytherapy, which is that we actually can induce radiation seeds into the same area in the same fashion. So we actually can take patients and actually have radioactive seeds and do very focal therapy here. It doesn't look like this is wanting to play. There we go. So this is something we did a long time ago, and it hasn't, it's not something that's frequently utilized, but I just want to show the capabilities that are available. So this is a patient who had a persistent lymph node, but had already received quite a bit of general radiation, wasn't really a candidate for more, so we actually did localized radiation therapy by injecting sort of these radioactive seeds under ultrasound guidance, and you can see one there, and you can see that seed's been placed right there. So in summary, I'll get back to the main talk here. I just showed you those videos there. And this has been done in China as a sort of trial in a couple of patients successfully. So in summary, our role really serves to sort of both in imaging. I showed you detection. We can access both the main pancreatic duct as well as the cysts. We can actually do microscopic imaging of the cysts. We can obtain tissue both for just diagnosis, but also hopefully increasingly for molecular analysis. For treatment, I didn't talk about stenting of the ducts, but you can certainly stent the bile duct in order to relieve jaundice. Many patients present with jaundice. We talked about relief of pain. We can potentially, in the future, may be possible to ablate certain cysts for certain early ampullary lesions, the site where the bile duct and pancreas sort of join the duodenum. We can actually resect early lesions there if it's appropriate. I showed you fiducial placement and the ability to place radiation seeds. And there's even been some studies, although they haven't panned out, but it's more proof of concept, that you could even potentially inject certain gene therapeutics in conjunction with other therapies. So I think increasingly we're going to play a role not just in the diagnosis of these patients, patients with pancreas cancer, but we really also are going to play a role in their treatment and assessment of their treatment going forward. So with that, I thank you for your time and the opportunity to be here today.